principally we're talking about three approaches. The open approaches, endoscopy and arthroscopy will come later, and we'll have a lot of discussion, so please don't think that you have not understood. But anyway, so now I'll talk about that. Let's divide the condyle into three parts, okay? Let's say head, neck and base. Now if you're talking about the head, or for any procedure of the head, we will do some sort of a preauricular incision. For the neck part or the ramal part, we will do some sort of a modification of the retromandibular or the Hind's incision. And for the base part, or for the angle part, this part, we will do some sort of modification of the residence or the submandibular incision. Are we clear? Preauricular, retromandibular and submandibular. Now we are looking at the modifications. Okay. Okay, so this is the high submandibular. We will talk about it. High submandibular, retromandibular, and this, as Lakshmi said, now this is the incision, which is the latest modification, or no, there are other modifications that Abhay Kamath will talk about. This is the incision, the modification of a preauricular incision. So let's start with the incision. Now we've seen all of these cases, right? I'm not talking about Alkaya Pravi either today because we know all of that. It's just the skin incision that changes. Inside it is pretty much the same, huh? So MIOS, right? Minimally invasive, not automatic surgery, but minimally invasive surgery, MIS. So from huge incisions that go till here, we've come to a very small incision, and Abhay will show you an even smaller incision. Again, let me just say 3-4 words about anatomy. Because this is the ear, we're talking about the incision. Huh? So this is the helix, this is the margin of the helix, this is the crux of the helix, this is the tragus and the intertragic notch. Now here the only thing to remember is two things. One is, look at this, that anteriorly when you are taking your flap, your facial nerve is at least 8 mm from the border of the external auditory canal. Okay, so you have to go even behind 8 mm. 8 mm to 35 mm it can be. But assuming it is 8 mm, so you have to stay between 0 and 8 mm from the external auditory canal. Alright? So we go as posteriorly as possible to the, as close as possible to the external auditory canal. That is one thing. That is anteroposterior. And superficial to deep, your nerve is, look where this is. Now, if you remember, we'll come to this again, okay? If you remember, we place a 45-degree incision here, right? Do you guys remember 45-degree incision the minute you see the temporalis fascia? I'll show this to you, but just remember why, all that, huh? Now that incision will be here. When we see the glistening temporalis fascia, we will place this incision here. When we see the fat, we will stop, okay? And then we will take, I will show all of this, but when we see the fat here, we will stop, and then we will put our instrument below the superficial temporal fascia, and here we will go. We will come here, we will touch the arch, okay? From here, we are coming here, we are touching the arch and then reflecting this flap. So you understand, the nerve goes into this flap. Basically, you've understood, I'll show you in the video. From above, we are coming down and reflecting the flap, and into the flap, we are saving the nerve. I'll show you again. This is what we are doing. Cutting here, seeing the fat coming down, and the flap, the nerve is going inside the flap. That is one thing that you have to remember when we see the video. Another thing that we have started doing, which gives us so much of exposure from so much of an incision, is that these tissues, okay, these are the tissues between the inferior border arch and the sigmoid notch. Now these tissues only have the masseter nerve and vessels. This is, at least as of now, they are not playing a very important role. So we've done maybe more than 250 odd cases of indecision. This area is what we clear. We take a bipolar. I will show all this to you. Just understand the theory. We take a bipolar and clear this entire area. Huh? So that is what gives us the access. Thoda bahut samajh mein aa raha hai? Okay. And we'll come back again. And then that is this area. And then this area is your disc. So we are placing an incision on the disc as well. Again, we will show you. So, okay, nerve. So we have to be just 8 mm, as in behind 8 mm, just as close to the skin as to the EAC as possible. From above, when we are coming, we stop when we see the fat, and we reflect the nerve in the entire flap. Okay, and stay on this. Now let me show you and then we'll discuss again. Okay. So now this is hydrodissection. Okay, you want to raise the skin flap away from the perichondrium, from the cartilage. Okay. So now you're placing the incision on the margin of the margin of the helix, going behind there on the crux. Then take. I need to come here. Wait. Okay, and then you can come either. This is fine. You've understood the incision, right? We're going here. You can see the. Coming down behind the tragus, and you can either stop here or you can take it down. You can either stop at the intertrachic notch or you can take it down. I'll show it to you again. This is your incision, okay? Marking from the margin, the crux, behind. See the tragus here? So your marking has to be, you have to pull the skin forward. You have to pull the skin forward and then place the incision. So your incision is behind the tragus. So here if you see, this is not visible, this is not visible, this is not visible. A part of it may be visible here, but that goes into the skin fold. Okay, so you can stop here also if you want. Later, you can start with, when you beginning you need a little more thing, so you can go till here, okay. Now let me show it to you. Hydrodissection, and then place the incision. That incision has to be supra-perichondrial, because you have to you'll reach the ear cartilage here, okay. The blood supply has to be maintained. You don't dissect the perichondrium of the cartilage. Leave a little perichondrium there, okay, and this is the flap that you have to raise. Alright, okay. Above you go on till you, and okay, you're still hugging the ear, okay. Go on till you reach the superficial temporal fascia, that white glistening thing. Till there you have to go. Here, see this part you have to be very careful. Again, leave a little perichondrium on. This is the tragus, okay. Leave a little perichondrium on the tragus, and here you stop when you just before you see the parotid you stop. Now see this white structure. One second. This white structure is your what is it? Glistening white. Temporalis. Okay, you see that, and okay, this all your arteries, one second, all your so everything is anterior to this, okay, because your incision is so far posterior, you have to take your superficial temporal vessels, everything anterior to that, and then here you will only be, and you're going as posterior as possible, okay, as near the EAC as possible, and here the only thing that you will have here will be the transverse facial artery, which you will identify and burn. If you go down, sometimes you will have the retromandibular vein, so that also you identify and burn. Okay. Now this is that avascular plane you will get. Okay, that is the perichondrium that you are leaving. Okay, just above the cartilage, perichondrium, and then you have, so if you're coming from top, you have the skin, subcutaneous tissue, then you have the perichondrium, and then you have the cartilage. So you have to go in between the subcutaneous tissue and the perichondrium. Understood? Above the perichondrium. Okay, that is your perichondrium, that is your temporalis fascia. That is your facial, transverse facial artery. Burn all of that. Then now inside everything is the same, okay. Now you have your 45-degree incision. Here you can see fat. One second. When you're placing this incision, just look very carefully, okay. That incision, and below that you will see those white, yellow globules of fat. When you see those yellow globules of fat, you stop. This is a 45-degree incision. Then you take your periosteal, go under that temporalis fascia, touch the zygomatic arch and cut that, keeping the fat intact. Okay, see that? Here. Alright, now when you've exposed that, you want retraction here, so just take a suture here. Now we are into that oblique incision, and we are cutting this just till we reach the arch. Okay, and now we are reflecting the whole flap above the arch anteriorly. Are we okay so far? Upar wala part is done. Now we have the arch. Now we have to go down. So down, what we'll do is we'll cut the capsule. Okay. Details of the capsule Sankalp will take, so I'm not showing you details of how to cut the capsule, but we'll cut the capsule here and then we'll go down and touch the bone. We've reached the arch. Okay, now there is the capsule, so we'll cut the capsule, and when we cut the capsule here, this is the ramus. Okay, so this is the ramus cut here. Alright, we have this, and then this is the arch, the oblique incision, the arch, the capsule which we've cut, and we have the ramus incision. So now everything is reflected anteriorly. Are we clear? When we reflect it anteriorly, here we have the sigmoid notch. Here we have the inferior border arch. This is the tissue that we have to bipolarize. Are we clear? We are going into the superior joint space here, okay? But again, he'll tell you further details. This is the, now you see, once you've cleared all of that, and once you've cleared all this also, the area between this is the sigmoid notch and the inferior border arch, okay? All that we've cleared. Now you see the exposure that we get. That periosteal is going to the anterior border of the ramus. Above that is the coronoid process. This is the anterior border ramus. This is the coronoid process. Here is half the ramus exposed. This is the entire arch, the articular eminence, all of this exposed. And the incision is still only so much. This is closure of the capsule. See that? So you place an incision in such a way that nicely you can close the capsule also. Are we clear so far? Yes. And the closure. Okay? Yes. Are we okay? Yes. So incision between the skin, so superficial subcutaneous tissue, then here it is cartilage and perichondrium. So you are above the perichondrium, below the subcutaneous tissue. This is fine? अरे यार जागो थोड़ा, fine? ठीक है. Then you come down here, go behind the tragus, come down till the intertrachic notch. All right? You come there, then you reflect. When you start reflecting, then you reach the superficial temporalis fascia here. Place that 45-degree incision. Go down, cut the fibrous capsule. Down you've cut the bone, and you're reflecting everything anteriorly. Okay? And once you do that, then the only thing that you have to cut is the area between the sigmoid notch and the inferior border arch. Are we clear? Yes. Done. Okay, I'm not showing you cases and all, no time. Are we going to? That is your indecision, huh? What is this? No, show me that forward wala thing. इसमें forward कहाँ है? Okay, see the results. The only thing that is visible is this one, because that's the only thing that is transverse, which is not along the visible, right? But that is the only thing that will be visible. Get it? Baki, there is nothing visible. Nerve injury, no nerve injury. Again, this is the only thing that is visible. Transient will be there, okay, because it's a small incision you are pulling. Transient will be there, especially if you are going very anteriorly for big ankylosis chunks. But if it's just a condyle fracture, just an eminectomy, there's that no transient injury also, and that too not an eye closure. There will be sometimes maybe the frontalis thing. Okay, this is the only thing that's visible, and that too it's like because we know that we have to look for it will be visible. Otherwise patients come back and say कि वो डॉक्टर तो बोल रहे हैं ऐसे झूठ बोल रहा है डॉक्टर ने तो सर्जरी तो करी नहीं. Right? I think you guys are still sleeping.
Show that previous slide.
हाँ. which one? ये? हाँ. फोटो खींचने के लिए मैं यहाँ भेज दूँगी अरुण. टाइम मत वेस्ट कर रहे हो. समझो. Okay, we've published, okay? This was when we had only 60 cases, now we have over 250. Maybe more advanced of counting. Okay, this is this thing over, okay? Now high submandibular incision, there was a lot of confusion, I said we'll clear it. Regular submandibular incision is when you have, this is the inferior border of the mandible, okay? Into the neck crease, 2 centimeters below that you place your incision, 2 centimeters below that you place your incision. That is Distance or regular submandibular incision. High submandibular, very clear cut. You identify the angle. Okay. Identify the angle just 2 to 3 millimeters below the angle. You place a straight line going for 2.5 centimeters. If you're beginning, maybe 3 centimeters. I generally take maybe 2 centimeters. Don't bother about that. Okay. Beginning, you do well. As a straight line. Okay. That's the only difference in the skin incision. Periangular, exactly the same, but you take because angle is like this, so you go like that. That is it. Skin incision. अरे यार ये एंगल से यहाँ पे आए, सीधी लाइन खींची, हाई सबमैंडिबुलर. यो एंगल के से यो करके यो खींची, वो पेरिएंगुलर हो गया. 2 to 3 millimeters only. हाँ.
When you say periangular, the very intention of saying. No, it's all right.
No, you're not talking to me, bhai. You're talking
No,
to
I'm
them.
talking to them. The very
The very intention of saying it as a periangular approach, number one is, you don't have to follow the anatomy of the angle. All you're doing is placing the incision just 1 centimeter below the angle of the mandible. Whether you want to access a higher condylar head or a neck fracture depends on the case. So you want to give an
1
extension.
centimeter, your periangular is 1 centimeter.
No, just at the angle region.
Yeah.
I
So
think
3
Andy would agree with
millimeters.
me. It was initially referred to as the Kent's approach, which never gained popularity. It's Myers who resurrected this incision. So your design variation happens based on your case per se. Suppose you have a condylar head, neck or a base fracture based on the SORG classification, you can go ahead with this. But when you have a higher component, you can give your posterior vertical extension.
Okay, head, neck, base, suppose we're talking about fractures. Head is to be dealt with a preauricular, whichever approach, whichever modification you want. The neck is to be either dealt with a retromandibular, which I'll show you, or as Bhai is saying, the periangular approach, because that periangular approach has that upward extension, okay? 3 millimeters below, 3 millimeters posterior, like that. Let's remember it like that. Are we clear so far? Yes. Skin incision, okay. Here now let's talk about the regular first time high submandibular incision that was introduced by Christopher Meyer. Remember I told you first day? We know this, right? Anterior to posterior artery vein, superficial to deep, marginal mandibular nerve and the two this thing. And even above the marginal mandibular nerve is? Node of stuff. Fantastic, okay. Now this is, I'm just showing you, okay, this is the thing, I'll show you how, but see this. This is the artery going posterior, that is the vein, and superficially is the nerve. Alright? How to reach, I'll show you, but these are the three things, like this you have to show, okay? Okay. Now again, now see the difference. Distance is, or your regular regular submandibular is, you are going below, okay, you are coming up. When you are coming up, or when you are placing the incision, you are subplatysmal. This is the only difference, okay, or the major difference. In a regular submandibular incision, you are in a subplatysmal plane and फिर आप ऊपर जाते हो, okay, subplatysmal plane and then you are going up. But in a high submandibular incision, this is your regular thing, okay, you've cut, where is the platysma? Here, this red thing is the platysma. So you are going beneath the platysma. Are we clear so far? Yes. Now come to, now see this. You are cutting, one is the skin incision is higher than the regular thing, that much we are clear? Yes. We are placing the skin incision, but we are going beneath, above the platysma. So you have skin, subcutaneous tissue, incision, dissection, platysma is here. Okay, I'll tell you why. तो वेट ना भाई, अभी तो मैं ऊपर हूँ ना, उसके रुक जाओ. हाँ, okay. This diagram is not very good, I'll show you. So this is, you're going here, you are above the platysma. This is not the platysma. This brown thing is the platysma. Alright? The brown thing is the platysma. You are here, and then once you reach the platysma, I'll show you that. When do you cut the platysma, I'll show you, but basically you stay above the platysma, reach a particular place, then cut the platysma, reach the masseter, then cut the masseter and go to the bone, but I will show you how. But principally this much you've understood, high submandibular, first you have to create a nice plane above the platysma. How? I will show you again. See, incision, angle to anterior, 2.5 centimeters max. Okay. Now, here you are above the platysma. Okay. And I will show you that plane again also, okay, first. अभी क्या करें समझाना पड़ेगा ये ना. See this plane? This is above the platysma. Okay, so in this plane you have to dissect all around from in an arch form from the arch to the anterior border masseter. Okay, you have to dissect all around. Again, I will show you another video of dissection also. You have to dissect first with a little bit with the scissors and then with your finger. I'll show you that again. Platysma is below, huh? See that? I've dissected with the scissors. Now I'm dissecting with my finger. All right? In an arch from the arch till the anterior border masseter. Now you are cutting the platysma, or whatever little there is. There won't be too much of platysma, but now you are cutting the platysma. The minute you cut the platysma, you are on the fascia of the masseter. All right? Now you've cut the platysma. The minute you cut the platysma, you are on the fascia of the masseter. That's where you will see your nerve. Generally, it will be your lower buccal nerve. All right? That is what I'm showing you now. Okay? Yes. And when you see the nerve, just dissect it a little bit. I'm showing you more to show you. Dissecting it more to show you. But that's your nerve. Below that is the masseter. Just above the masseter now, you're supposed, don't cut the masseter. Take a sharp artery and go pierce the masseter, go onto the bone and open the artery. Okay, so that you've opened the artery. Okay, and you're on the bone. Okay, and then because the reason that you'll be able to, from here you'll be able to reach the condylar base is that remember the fan shaped dissection that we did? That is the reason you'll be able to pull. If you don't do that, you won't be from here, you won't be able to reach here. Okay? So, skin incision 2.5 to 3 millimeters below the mandible. Cut the skin and stay in a which plane? Supraplatysmal. Please, I'm talking about the high submandibular. Regular one is subplatysmal. Regular, everything is subplatysmal. But these two things that we are teaching you, we are teaching you is high submandibular and retromandibular. From a small skin incision, you have to have a lot of dissection to reach the condyle. Okay, so you have to stay supraplatysmal. Stay supraplatysmal. Then you reach then you cut the platysma, open the platysma, and you will be on the masseter. On the masseteric fascia, you will have the nerve. Dissect the nerve, go above the nerve into the masseter. You go and open up your artery. Are you okay? Yes. I've taken too much time.
Sonal, when you think about a periangular approach, remember it's a game of retractors. When I say it's a game of retractors, it basically means when you place your incision on the skin subcutaneous tissue, you need to dissect 360 degree, as she put it across, saying a fan-shaped dissection. What you need to remember is when you keep two Langenbachs on either side of the incision and try to reach the condylar head, neck or base, you're never going to reach there. So what is horizontal and incision automatically traverses to become a vertical. When you have the incision becoming vertical, you can reach the area. And regarding where you're going to open the masseter is of significance. Are you going to open the masseter in its belly or on the posterior vertical border is case preferred or the surgeon's preference. I prefer to open the masseter on the posterior vertical border. It becomes easier. So remember, your periangular, which is initially a horizontal incision, becomes a vertical once you release the retractors from the anterior end, which gives you so much more access. And she also spoke about the platysma. Now, and you know that the platysma gains its attachment from the inferior border of the mandible. That's the reason you have a scant platysma there. What you need to identify is the glistening parotidomasseteric fascia, which houses your epimysium or the neural network there. You need to find the danger zone or the zone between the two branches and dissect to reach the bony component of the mandible.
Parotidomasseteric fascia we will come to now. Here there is no parotid. You will never ever get the parotid when you are doing a high submandibular incision. You may get it if you are doing a periangular. Do you get it? Right?
As you go higher up.
Exactly. As you go higher, you will get the masseter, the parotid. Over here, we are talking principally only the high submandibular incision. You will never ever get the parotid. Alright? Now we are talking about the higher incision, which we have written and we've published that for a neck fracture or anything in that area, you use the retromandibular. Our modification is the subparotid incision. We never ever go inside the parotid. We have never needed to. Okay? We just look at the parotid and we retract it upwards. I will show you how. Okay, now again, diagrammatically we will understand first and then the video. Diagram ka hai? See, this is your incision. Now where do you have to be? Just below some 4-5 mm below the ear lobule, and then you palpate your posterior border mandible, and then just behind the posterior border. So basically the idea is to hide the scar in the shadows of the mandible. Same thing here. The idea is to hide the scar of the scar in the shadow of the inferior border mandible. Here is shadow of the posterior border mandible. Huh?
Yes.
Okay, so here again 2.5 centimeters. In LEs it's written 3 to 3.5 centimeters. We do not believe it when we don't need it also. I'll show you how. Okay, so here you've placed your skin incision. Skin subcutaneous tissue will, and again the same thing. Go supraplatysmal. Same thing, okay? Supraplatysmal, open it and see कि अच्छा भाई platysma नीचे है. Into that plane again that same thing. First create a plane with your scissors or whatever you use. We use scissors. And then your finger dissection. Same thing here to here. That is what will give you the mobility of the flap when you move it. Okay. Now the difference here is that, see this. This is your parotid. This yellow thing is the, can you see this? This is the parotid. This is the masseter bone. Okay. Now here this is a higher incision. We are cutting the skin. This is subcutaneous tissue. This is the this is the platysma. Okay. Now the platysma, the SMAS and the parotid capsule, ये ऐसे अलग-अलग नहीं दिखता in the patient. Okay, it is pretty much one single thing. Earlier we used to cut the parotid capsule and then suture it alone with a subplatysmal plane. In a subplatysmal plane. The problem was, see this that layer which I am talking about. No, this you have to suture it airtight, watertight to prevent a parotid fistula. अब जितना पतला होगा, if you try to close a thin thing watertight, it might open or you might get a fistula. That is why you want to leave the platysma also onto that. Okay, so platysma, SMAS, parotid capsule, whatever you want to call, all of that together you are leaving. So two reasons for going subplatysmal. One is you want retraction. Like I said, this is the vertical only, but vertical again goes more vertical. But so one is you want more retraction. Two is you want to leave a thick enough layer to close it properly so as to prevent the parotid capsule fistula. Okay, you'll understand more as we go along. But this much understood. So skin incision and supraplatysmal dissection. Okay. Now you cut one single straight cut wherein you are cutting parotid platysma, parotid SMAS, parotid capsule, everything together, opening. Take maybe put two tagging sutures, holding sutures. Here now you have the parotid. You don't go into through anterior, posterior, nothing. I will teach you maybe another approach. This is the approach that we follow. Subparotid is what we do. We see the parotid, come to the bottom of the parotid and just lift it up. Okay? Lift it up and below now what do we have? Masseter. Fascia of the masseter. On that what do we have? Nerves. Again go as superiorly as possible, as I was saying. Go as superiorly as possible. Look where you want to enter. And then you enter with that sharp artery. We are not cutting the masseter to prevent bleeding and to prevent edema. Okay? Go into the masseter and just open up your this thing. It opens like a door. Okay, then inside you just do periosteal, subperiosteal dissection, and you see, because of your dissection here, you see how much of exposure you get. ये चलेगा? हाँ, see skin. Okay, this is your supraperiosteal dissection. Same way that you were supposed to do below, and this is a better thing. Okay, supraperiosteal first with your, create that plane with your scissors and then with your fingers. The older the patient, the easier it is. Young patient will tight everything, it will be very difficult. Now wait, pause. That is your incision through all those 3 layers, okay? You won't see them separately, but that's the incision. Okay, and then you place one suture here, one suture there, just to know that these are the things that you have to close. Are you guys with me?
Yes.
See that below that is your parotid, huh? ये देखो, ये ऐसे उठाया. Okay, that you're taking a suture through one this layer this side, one layer that side. As in one part of the layer this side, that side. You understand, right? And then see, once you've opened that up, these are those 2 sutures. Now you will have your parotid. Come right down. There are branches inside the parotid. You don't want to do anything to them. Come right down and then just lift the parotid. Parotid lifted. And you're on the masseter and you have your nerves. Same thing that we had there in the high submandibular incision. Again the same thing, just artery, open up the masseter and go inside. Okay? Okay, go inside, do subperiosteal dissection and that's it. Okay, आगे चलो. 1 second. Okay, this is, what was this? 1 second. Same thing, okay, same thing again. But why are we showing this? What this we've shown? Oh, no, wait. So I'll show you, it looks so beautiful, that dissection. 1 second. See this? Okay, see this now. That whole thing is platysma and then beyond. Okay, so you need this kind of a tunnel inside. Okay guys? You need this kind of a tunnel, that will give you retraction, huh? Okay? मैं बहुत कमाल की सर्जन हूँ. I don't even know what I'm doing. Okay? So that is one this thing, and then that is the other one in which you have to close. Okay, guys?
Sonal, what Arun said has a genuine point. Arun, the very concept of doing these incisions, whether it's retromandibular, whether it's periangular, the technique is to stay supraplatysmal. You're staying at the skin, subcutaneous, and below the subcutaneous plane you create your path. Something like your rightidectomy approach or your facelift.
You know, you're right, because that is your smash layer where you've reached. I didn't even think about doing it like that, but that's your smash layer and that's what you have to pull. Correct, no? And we'll talk about it again. यार मेरा बहुत overtime हो गया है.
Sometimes when you're doing in this area as a beginner, you cannot see nerves. There is a confusion. Where is the nerve? You have fibers and you get confused with bleeding. The thing is, imagine the nerve is coming towards you and you dissect horizontally, not vertically like this. Right? So maximum chances you will not damage the nerve. You know, going to the parotid. This thing that if this is the nerve, it's coming like this down, right?
Sir, I think you should stand here and explain.
Standing का वो problem है भाई मुझे.
Look at him, guys. Clap for him. Fantastic. Bengali.
See this incision. This is vertical, right? So this is vertical, right? But the nerve trunk is like this. Dissect along the course. Imagine it if you don't see those. Actually, the marginal mandibular. Marginal mandibular is very thin and is very superficial. And lot of studies you see and all, sometimes you don't see anything. Confused where is the nerve. As a beginner, you don't see nerve. Dissect along. That's it.
Okay, done.
The course of the yes.
This is closure of that thing. See? This is that closure. See that? We put those holding sutures and we close that. Okay? And it's one nice thick flap because it's all those 3 things. What are those 3 things that we have? Platysma, smash, parotid capsule. Okay? Whatever little bit only we have, but still all those 3 things. Okay, done. Alright, questions. Just one question. Okay, we're already over time. What do we have next? अबे bye. Arey tu come.
No, you finish.
No, I finished. Overtime. Come. Questions? Any questions till he comes? He's my brother.
From another mother.
From another mother. Abhay Kamath. And we are brother and sister because we have the same extreme love for TMJ. Super amazing surgeon and even more amazing person. That's his introduction. Questions? Have we understood? Yes. Incision, high submandibular and retromandibular. Completely clear? I'm sorry I myself have taken 10 minutes extra, but the point was कि एकदम ऐसे ठोक के समझा दूँ because a lot of y'all will not be coming to dissect tomorrow, right? That is why yes.
When we are giving the vertical incision, how should we stop at that parotid that we have reached without cutting the substance of the parotid?
You are not cutting the parotid. We are not going into the parotid at all. Huh?
That's
You are
what
much superficial.
How to stop there? I'm asking is when giving the incision.
Okay, so you have the skin. So धीरे-धीरे जाओ. Go slowly. Skin.
No, after the fascia, ma'am. When we are cutting the three together, this mass, parotid, capsule, and
okay.
that
Same thing. Go slowly. See, it is difficult. Okay, I am making it appear maybe easy. It is difficult. It's not like I have been born like this. Okay, it is difficult, but doesn't matter. Keep patient. See, that's the whole point of surgery. Okay, never say no. It's not like these things are some God only who's doing it. We all can do it, so you all can do it. Okay, just keep at it. Go slowly. Take your time. Place bigger incisions if you have to. It's all right. Okay, in here, it's all right because you don't want to injure your nerve. You want to be absolutely this thing. So go slowly. Keep checking. Acha, am I there? Parotid will be those lobular kind of fat-like thing. You know. Okay. So just go very slowly with a sharp knife or maybe a dull knife. Okay, and keep seeing. Acha, ठीक है, पहुँचे? Have I reached? So yeah, it's like very, very careful incision.
Why do we not go supraparotid instead of retroparotid?
I am not going supra or retro at all. I am only going subparotid. The entire parotid I am lifting up. The reason is I don't want to. Because of this, I have never ever, not just me, my entire unit, no nerve injury at all. Neither with the high submandibular nor with the retromandibular. Ever in any case over the last 8-10 years. Never.
Stay above the parotid between the capsule and
Above nahi bache. We are taking the parotid up and working below the parotid.
I got this one. If we do that,
If you can do whatever you want, he'll tell you what else you can do. Okay, this is our way that I am showing you, which is absolutely safe. Alright? In all the other approaches, there have been incidences of nerve injury which have been mentioned in the literature. Okay? Supraparotid, I've never heard of this. Have you?
anterior parotid.
All that you can do. Acha, another thing is transmesenteric anteroparotid. Transmesenteric falana. See, all those incisions are transmesenteric only. Okay, whether it is anteroparotid, posteroparotid, sub, supra, whatever is what you do above the masseter. Right? So whatever you are doing to the parotid will tell you whether antero, postero, midrio, whatever. Finally, after that, all those approaches are transmesenteric. Okay, so T-map and all, big deal. I mean, it's all TM only. All of them are transmesenteric. It's just what you do to the parotid, and then whatever you are comfortable with, please go ahead. This is what we are comfortable with, and which gives extremely good results. And
Somebody there asked a question. I don't know who. I think you, madam. What was your question about?
After entering we are giving a vertical incision in the fascia, right?
Stream. Speak up.
So how do we protect the parotid that we are not entering and the
How
nerve
do you predict that you are not into the parotid?
and the
Simple.
nerve as well?
Once you placed your incision, whether it's 0.5 centimeters below the lobule, and then you transect through the skin and subcutaneous tissue. Once you are at the subcutaneous tissue level, you do your finger dissection or whatever kind of dissection to gain access to that area. What is the next layer you're seeing? You're seeing platysma. You release the platysma. This is the simplest way you can do things. Incise the platysma. Don't use your cautery. Gently incise the platysma. Once you've incised the platysma, what do you see? You see the parotid acini, the parotid globules. Once you see the parotid acini, instead of dissecting perpendicular, your dissection changes from perpendicular to anterior. So once you've done your anterior dissection, what is the cutoff point to reach your mandible? You need to identify the anterior edge of the parotid gland. or the parotid gutter. Once you've identified the parotid gutter, you pull the parotid backwards. And when you do that, what becomes evident? A masseter. The answer is there. So your key is to identify the parotid gland AC9.
It looks like fat, I said, right? It will look like fat. That is your parotid. Whatever looks like fat when you are below the platysma, and that is the parotid. It is not fat. So either you go anterior to the parotid or you go below the parotid. Just lift the entire parotid. You all can hear me, right? Okay? So anterior to parotid you are going and then pushing the parotid back is what Bhai is telling you. We locate the parotid and we push the parotid up and we are below the parotid. But we are always on the masseter. Wherever we go, finally we will reach GDC Ahmedabad Gyan.